Let's jump right in. Today's explainer is a step-by-step dive into the pathology of vascular tumors. We're looking at a huge, honestly fascinating spectrum here. We're talking everything from everyday birthmarks that you've probably seen a million times, all the way to some incredibly rare, highly aggressive malignancies. So, let's just get straight to the facts.
Here is our game plan. 1. Classifying vascular tumors. 2. Benign tumors and ectasias. 3. Reactive and specialized tumors. 4. Intermediate-grade Kaposi sarcoma. And 5. Highly malignant angiosarcomas. Let's do it.
Starting with Section 1, Classifying Vascular Tumors.
To make sense of all this, we classify these lesions into 3 distinct clinical buckets. You've got your benign neoplasms, like hemangiomas, which are relatively harmless. Then, right in the middle, we have intermediate-grade tumors. Think Kaposi sarcoma. And finally, on the far end of the spectrum, the highly dangerous malignant neoplasms. It's a really helpful mental roadmap to keep in mind as we go through this.
Now, if you're a pathologist looking through a microscope, how do you actually tell the safe stuff from the dangerous stuff? Well, there's a foundational rule of thumb. Benign tumors usually have these very obvious, normal-looking vascular channels. They're filled with blood cells and lined by just a single, neat layer of normal endothelial cells. Malignant tumors, though, total chaos. They're heavily cellular, they look highly atypical, and they rarely ever bother to form well-organized blood vessels.
All right, moving on to Section 2, benign tumors and ectasias.
First up are vascular ectasias. Now, it's absolutely crucial to remember that these are not true neoplasms. They aren't newly grown abnormal tumors at all. By definition, they are just permanent dilations of pre-existing small vessels, your capillaries, venules, and arterioles. Basically, the existing vessels just lose their normal tone and stretch out permanently. A classic example of this is hereditary hemorrhagic telangiectasia, or Osler-Weber-Rendu disease. It's an autosomal dominant disorder caused by a very specific glitch, mutations in the TGF-beta signaling pathway. Because of this mutation, patients are literally born with widely distributed, dilated capillaries and veins. And the real clinical danger here, these stretched-out vessels are structurally super fragile. They're highly prone to spontaneous rupture, which means patients often deal with severe nosebleeds, GI bleeding, or blood in their urine.
Now let's compare 2 true benign neoplasms, capillary versus cavernous hemangiomas. The clinical differences between these two are pretty stark. Capillary hemangiomas are the most common type. They're made up of thin-walled capillaries. And the juvenile forms, you might know them as strawberry hemangiomas, do something amazing. They grow rapidly at first, but then they actually tend to regress completely all on their own by age 7. Cavernous hemangiomas, on the other hand, are a totally different beast. They form these large, dilated, blood-filled channels. They plunge deep into tissues, they're infiltrative, and crucially, they do not go away on their own. They usually require surgery.
You can clearly see the structural difference when looking at these tissues. In a clinical setting, a hemangioma of the tongue looks like a prominent, raised vascular mass. But when you check the histology of a juvenile capillary hemangioma under the microscope, it all makes sense. You see those classic thin-walled capillary spaces, completely packed together just like we described.
Let's shift gears to Section 3, Reactive and Specialized Tumors.
We've got to start this section with the glomus tumor. This is a benign neoplasm, but it is exquisitely painful. Interestingly, it doesn't actually arise from endothelial cells. Instead, it comes from modified smooth muscle cells of glomus bodies. These are specialized little structures involved in regulating your body temperature, usually located at the very ends of your digits, typically right under the fingernails. So you've got a tumor originating from support cells, not the vessel lining, and its absolute hallmark symptom is just intense, extreme pain.
Next is bacillary angiomatosis, and its pathogenesis is like a masterclass in how an infection can totally hijack your body. It all kicks off with an opportunistic Bartonella bacillus infection, often from something as simple as a cat scratch. These bacteria manage to adhere and actually enter the host's endothelial cells. This invasion tricks the host into producing a protein called hypoxia-inducible factor 1, or HIF-1. And here's the kicker. That HIF-1 drives the massive overproduction of VEGF, a growth factor that aggressively stimulates the abnormal growth of new blood vessels. And the results of that runaway VEGF production are very visible. Clinically, it presents as these characteristic cutaneous lesions, red papules and nodules popping up on the skin. Under the microscope, you'll see intense capillary proliferation, all driven by the host's own hijacked growth signals, mixed in with acute inflammation. To the naked eye, it looks like a classic tumor, but fundamentally,
It's just a reactive process to a bacterial invader.
Moving right along to Section 4, Intermediate-Grade Kaposi Sarcoma.
So Kaposi sarcoma, or KS, is notoriously virus-driven specifically by human herpes virus 8. But here's the catch. Having the virus usually isn't enough on its own. For KS to actually develop, it crucially requires altered T-cell immunity. That is exactly why we see it so heavily associated with AIDS, or in patients taking immunosuppressants after an organ transplant. And much like the bacterial infection we just talked about, KS development relies heavily on triggering those angiogenic pathways downstream of VEGF receptors to fuel its growth.
Clinically, Kaposi sarcoma lesions evolve through a very specific three-stage timeline. Stage 1 starts with patches. These are initial red-purple macules, usually showing up on the lower legs. Give it time and it progresses to Stage 2, plaques. These lesions get larger, they raise up, turn a bit more violaceous, and we start seeing plump spindle cells in the tissue. Finally, it hits Stage 3, nodules. At this point, the lesions are distinctly neoplastic, completely packed with dense sheets of proliferating spindle cells.
Looking at the gross pathology, those coalescent red-purple macules and plaques are very distinct on the skin surface. And when you look at the histology of that final nodular stage, you can perfectly see what we just described. Those sheets of plump, proliferating spindle cells are aggressively taking over the tissue, marking that clear transition into a true neoplastic state.
Finally, Section 5, Highly Malignant Angiosarcomas. Let's talk about the stark, real-world causes of hepatic angiosarcoma. This is a highly malignant endothelial tumor of the liver, and it has some wild associations with very specific environmental carcinogens. We're talking about arsenic, which was used in certain pesticides, thorotrast, which was actually a radioactive contrast agent they used to use in medical imaging, and polyvinyl chloride, or PVC, from the plastics industry. The truly scary, critical thing to note about all of these agents is their incredibly long latency period. We are talking years, sometimes decades, between the initial chemical exposure and the sudden development of the tumor.
The sheer destructiveness of these malignancies cannot be overstated. You can have a grossly invasive angiosarcoma that heavily infiltrates major organs, like the right ventricle of a heart. Histologically, these are moderately to poorly differentiated. You'll see dense, chaotic clumps of atypical cells trying to line whatever distinct vascular lumens are left. It is locally highly invasive, it metastasizes readily, and it is structurally devastating to whatever organ it sets up shop in.
But this brings up a tricky diagnostic puzzle. What happens when these high-grade angiosarcomas are so poorly differentiated that they completely lose their structure? They just look like a solid, messy mass of spindled cells with zero obvious blood vessels. How can a pathologist even tell it's a vascular tumor? Well, they use immunohistochemical staining for very specific endothelial markers, namely CD31 and von Willebrand factor. These markers will literally light up under the microscope, confirming the vascular origin of those tumor cells even when the overall tissue architecture is completely gone.
Okay, let's quickly recap the absolute core takeaways from this explainer. 1. Vascular ectasias are just dilations of existing vessels, not true new tumors. 2. True vascular neoplasms derive from either blood vessels or lymphatics. 3. The vast majority of these tumors are benign, meaning they form obvious vascular channels lined by normal-looking cells. And 4. The malignant tumors are the complete opposite. They're solid, highly cellular, lack defined vessels, and show clear, dangerous atypia.
Everything we've covered today is drawn directly from foundational pathology principles. By looking at these textbook key concepts side by step, we've built a solid, factual framework for understanding how these incredibly varied vascular lesions actually operate.
So I'll leave you with this to think about. We've seen that vascular tumors span from simple, spontaneously regressing birthmarks all the way to deadly cancers driven by viruses or old industrial toxins. But they almost all share common angiogenesis pathways, like those VEGF signals we kept seeing. Given that, how might future therapies better target those shared pathways to shut these tumors down? It's a massive frontier in medicine right now. I hope this explainer shed some light on the subject